Alright guys, hello. I am going to be filming your first video for Renal. Today I'm going to do assessment labs, just kind of like your introduction and kidney stones. Being honest, there's not a ton of content on this kind of stuff. It's just kind of like introductory, but it's very, very important to understanding renal as a whole and like AKI, CKD, and the processes that you're going to be talking about in the next few weeks. So yeah, I do want to say before I jump into renal, and this isn't meant to scare you guys, I'm just relaying what like my experience was. I would definitely say renal was probably the toughest exam. My cohort got chewed out after the renal exam because we did not do great as a whole. That being said, like I'm pretty sure I got a 92 on it, but I remember like it was the exam that I felt the most like just kind of wishy-washy when I was taking it. So that being said, like I don't know, maybe it was just my cohort's study habits, maybe like we just didn't understand it as a whole, I don't know. But I just wanted to make you guys aware of that so you know what you're getting yourselves into, and so that way you guys don't make the same mistakes, and so hopefully you can get on top of it and be proactive with your studying. So starting with renal. Okay, so renal system is lots of functions. Very important. I would say like the three biggest ones are the kidneys obviously regulate blood pressure through the production of aldosterone, and then they also filter toxic waste out of the body, so they help to keep your blood clean, and they regulate water volume, concentrations, pH, acid base, fluid and electrolyte balance. They do a lot. The other thing with the kidneys is they produce renin, which helps to regulate blood pressure as well. And then also they produce erythropoietin, which is what controls red blood cell production. Basically, erythropoietin stimulates the bone marrow to produce red blood cells, so it's kind of like a process. That's important. All of this stuff that I'm talking about today with renal, it seems really like introductory, but if you understand this, it will make so much more sense when AKI and CKD come along, because you can like actually think through it and like understand what your clinical manifestations are going to be. Vitamin D is also synthesized with the kidneys, and then obviously the kidneys produce urine. You don't really need to know like the A and P, the kidney, like the layers, all that fun stuff. Yeah. We don't excrete everything in the kidneys. That's important to understand. Like some stuff does like stay in the blood, stay in the body. So like don't think that we just pee out everything. I will never forget. I think one of my most humiliating times in nursing school is when Dr. Schneider, like, I'm pretty sure we were talking about like Foley catheters. So it wasn't even with renal. It was with like the next unit you guys will do. I can't think of the word right now. And he like asked a question and I responded with pee. Like I think I said like the patient, it was with it was with catheters. And I was like, well, the patient has to pee within 6 hours. And he like made fun of me for saying pee and went on this long tangent about how it's a funny word. And I was like, well, that's what they say in the hospital. So like, but yeah, I felt really embarrassed. Anyway, okay, sorry, you guys did not need to know that. Fluid balance, we already talked about that. Aldosterone, so we talked about that. Antidiuretic hormone is also a really big part of the renal system. So if you guys remember from like patho with diabetes insipidus, that's characterized by large amounts of dilute urine because you have not that much antidiuretic hormone. So if you don't have antidiuretic hormone, you're just going to keep excreting everything. Whereas if you have more antidiuretic hormone, you're going to be holding on to everything. So you're going to like have signs of dehydration. You're going to have like really concentrated urine, that sort of thing. That's all I have for the like basics of the renal system. So moving into the labs, so the first one I have is potassium. Very, very important. You guys are going to talk about potassium a lot with this unit just because it really plays into effect. So an increase in potassium leads to an increase in aldosterone. So we talked about how that can affect blood pressure. The normal potassium is 3.5 to 5. I'm sure most of us have that memorized by now. And obviously, like if we take a diuretic, then unless it's like potassium sparing, your potassium's gonna lower with diuretic use. If you have kidney disease, it's gonna raise. So that's why it's so important, and why we'll talk about it a lot, is like potassium. One way you can tell if someone's developing like AKI and CKD is if they have elevated potassium, because they're just like holding on to everything and their kidneys aren't functioning properly. So then on the opposite of that, like hemodialysis, which is a treatment for like kidney disease, it helps clean the blood, that will lower potassium. And so, potassium is obviously really important for like nerve function and like muscle function. And so, just think about that and like remember what it does, what kind of food that's important. Dr. Schneider likes to ask nutrition questions here and there, and I feel like there were a couple on this exam. So like leafy greens, bananas, citrus, that all has potassium. And so like potassium, like if your kidneys aren't functioning properly, you might be on like a potassium restricted diet. So like you need to know what foods have potassium. So if a question was like, your patient has blah, 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 they're on a potassium restricted diet, like which one of these should they not have? Like you can pick it out. I've had that question several times on like ATI. I'm not really going to talk about, I don't know if you guys talked about C-big-K-di. It's an acronym, so it stands for calcium gluconate, bicarb, insulin, glucose, K-exalate, dialysis, and intake of potassium to less than 40 milliequivalents. That is all the ways to lower potassium that we're going to use, and you guys will talk more about that like later. But I just wanted to kind of bring that up. And so I'm not really gonna, so like K-exalate, okay, actually I will talk about this because this is really important, and I know there was a test question on this, so I'll talk about it in a couple different places. So K-exalate is one of the medications that you absolutely have to know for this exam. It's very, very similar to lactulose. So if you guys have ever had a patient on lactulose, you know it, because basically lactulose makes you poop. So like you're constantly cleaning those patients. I had a patient like that at my adult health 1 clinical, and it was rough. But basically that's what K-exalate does, is it makes you excrete the potassium through your stool. And so they're going to have really loose stool, but they have to have bowel sounds, because obviously if they don't have bowel sounds, then they're not going to be able to excrete the potassium that the K-exalate is like trying to do, if that makes sense. So I know we had a question that was like, which of these assessment findings is most important pertaining to K-exalate? But don't like, I would maybe just like think about what I said, but we'll talk about it more as we go down the line. So that is potassium. So then your BUN, your BUN, your blood urea nitrogen. So nitrogenous urea comes from the breakdown of protein. And so basically that tells us, BUN tells us how well the kidneys are doing at excreting urea. So it is a blood test, so you can see this with your BMP as well. And normal ranges, everything says different, but the one I have written down is like 8 to 25. And if I'm being very honest, like it's pretty obvious if it's out of range from what I remember. So that being said, like as like kidney function decreases, our BUN is going to rise because we can't get rid of that urea. The one thing though with BUN, and this is why like it's not like the best lab value for kidney function is because like there's a lot of things that can influence it. So like for instance, it's really sensitive to fluid. So like if you're overhydrated, then that means you don't have as much protein intake, which means that you'd have less urea, which means your BUN is going to be low. Whereas like if you're overhydrated, or not overhydrated, sorry, if you're dehydrated, your BUN is also going to be high, because your body is like breaking down the protein because you don't have the fluid. Other things, GI bleeds can make it high because if you remember, blood has a source of protein. So, like, your body's going to be breaking down a lot more protein than normal. It also will be high in like elderly patients because their kidney function just like decreases. And then if you have any sort of condition that's like breaking down muscle, so like if you have rhabdomyolysis, for instance, if you remember that from patho, that will cause your BUN to rise as well. But like I said, this on its own doesn't give us a lot of information about the kidneys. Like we have to use this with creatinine if we're going to look at the kidneys. We can't just look at this on its own and be like, oh, this person has renal failure, because a lot of times when this is elevated, it's just from dehydration. And then azotemia is your increase in nitrogenous waste products in the person's urine. I have that written down. So that was BUN. So then creatinine, which is the other one that I mentioned, is like creatinine is the like most useful in determining like kidney function. So unlike BUN, you can look at creatinine and be like, oh, like this person has decreased kidney function. Sorry, my voice is like losing my voice. So normal creatinine, 0.6 to 1.2 is the range that I've always had. It can differ depending on men and women, but like you don't need to know that. And it can also vary depending on like age, race, body type, that sort of thing. But basically it tells us like value of nephrons that are being destroyed, because creatinine is another byproduct of like protein and muscle breakdown. So like theoretically this could be elevated with with dehydration, but like it's very rare that that's going to be the case. Usually it's going to be from sorry, I just like lost my train of thought, but usually elevated creatinine is going to be from kidney disease. So the way that we figure out creatinine clearance, which is like the creatinine test, is so creatinine clearance is 95 to 135, and it's a blood and urine test, and you are collecting 24 hours worth of urine, and then the blood is taken. So okay, so you have creatinine, which is the 0.6 to 1.2, and that evaluates kidney function because it shows like the product of protein, creatinine in the blood. And then you have creatinine clearance, which tells you even more, and that's telling you like how the kidneys are working to remove that creatinine. So like if you think about it, like creatinine is in the blood, and then creatinine clearance is how you get rid of it. So 95 to 135 is like the reference. And to do it, you do a 24-hour urine test, like urine collection, and then you do a blood test after. I remember we had a question, I think it was like it had 4 pictures, and it was like, which piece of equipment do you need if you're going to do a creatinine clearance? And the answer was, so if you work in a hospital or even at clinical, maybe you've seen this, but there's like a big, like, it's like orangish red jug. If you ever have that, it's for a patient that has a 24-hour urine collection. So that was the answer, because you need to collect their urine for 24 hours. You also need to remember, like, you discard the first void and then collect everything after that. They'll usually have a sign on their door, and you keep it on ice. So those are all like nursing application questions that he could definitely ask you about that. And so then the reason why creatinine clearance is most important is like that's GFR. So creatinine clearance and GFR go together, and I remember I got confused on that, and I think I'm kind of like confusing myself. But GFR is like, so GFR tells you how well the kidney is removing waste from the body. So if you think about it, it goes like creatinine and then creatinine clearance and then GFR. And GFR is another one of those numbers that like it can vary on age, it can vary on gender, but bottom line is the lower you are, the worse you are. So there's like a diagram I can think of. If you're like less than 60, that's like really bad. Normal is 125, but like really anything above 90 is good. And then less than 15, this is important, I'm pretty sure we had a question on this, less than 15 GFR, you like need treatment for kidney failure. Like you need dialysis, you need transplant, like you're not going to recover on your own. I hope I didn't confuse you guys with that. Like I said, you need to know the normal creatinine, and you need to know that that's associated with decreased kidney function if it's elevated. If you have an elevated BUN and an elevated creatinine, then that means kidney function isn't right. But if you have just an elevated BUN and a normal creatinine, then it's probably dehydration. Creatinine clearance, really the biggest thing you need to know is just the 24-hour urine collection, the equipment, the nursing application for it. And then GFR, you need to know that that's like the best indication of how the kidneys are removing waste. And that if you're less than 15, you need like dialysis or treatment or transplant. And that like above 125 is like pretty good. So then specific gravity, this measures the kidney's ability to concentrate urine. Once again, this is like a couple different ranges, but the one I have is 1.016 to 1.022. So anything, I always get confused with specific gravity. I don't know why. It just like, so the lower it is, the more like water is in your fluid. Because if water is in your fluid, water, like your urine is composed of water. This is so bad. I'm so bad at explaining things. I'm sorry, y'all. So like if you think about it, specific gravity is measuring like the concentration, like the particles in your urine. So if you have not a lot of that, then that means that you have an abundance of fluid. So like that could be when you have diabetes insipidus, you're overhydrated. And then if you have an increased specific gravity, that means you're dehydrated because there's not as much fluid compared to solute. And then that could mean like you have increased ADH, like antidiuretic hormone, because you're holding on to fluid. So like if urine is really concentrated, it's gonna look dark. Remember that. That's why like when you're dehydrated, your pee is like dark yellow. Okay, so that is all I have on labs. The next thing I have is kind of going back to the urine sample. It's just a couple different ways to collect urine, because obviously urine can tell us a lot about the kidneys. So a urinalysis, a UA, looks at like a whole bunch of things. So like color, it looks at ketones, protein, pH. I don't know if I said that one already. So like my community health clinical, I was at the OB clinic 2 weeks ago, and I was doing a whole bunch of urine dipsticks, and like we had a girl who she was like spilling protein. Like her dip had like a 4+ protein, so they were worried about preeclampsia with her. So this just kind of tells you like, are they spilling protein? Do they have preeclampsia? It can also talk about UTI because you might have leukocytes, white blood cells in your urine. A culture is where you're going to incubate the sample. So you're going to look for bacterial growth. So that is a clean catch, has to be like usually sterile. So a midstream catch, this is when you're collecting urine. So you instruct your patients to like clean their peri area. They start to void, and then you catch the sample to fill up the cup like mid void, and then they finish in the toilet. So like it's not like they start peeing immediately and you like start filling up the cup. You let them spew a little bit out and then you catch it. You don't want to let any sample sit. You want to send it, but especially a culture. You can take it from a Foley, but you cannot use it from the bag. So if you're a tech, you maybe have had to do this, but basically what you do is there's like a little clamp kind of up near the top of the Foley by like the patient's leg, like peri area. And so you clamp it. And so like when I did it, I like walked into my patient's room, I clamped it, and then I like did some stuff on the computer for like 5 minutes. That way I could give the patient time to like produce urine. You don't want to leave it clamped for like more than 15 minutes, I'm pretty sure, but give them some time to produce urine, and then you attach a syringe or like a vacutainer. I've used a syringe, and you just pull back and you get the urine that you need. And so then that is like sterile, basically. If it doesn't have to be a sterile catch, so if it's not a culture, like you can just get it from the bag. But don't forget to unclamp. And then sensitivity can also be looked at with urine analysis, which is like looking to see what antibiotics you're sensitive to, but we'll talk in a little bit more about that because there will be a question on that. Oh yeah, this. Okay, the other thing I have on here that you guys should probably look at. So there's like a whole bunch of diagnostic procedures for like renal and ATI. I don't know if he talked about it with you guys, but he told us about it. He was like, here are some pages you should look at. I did not look at them because it was diagnostic procedures, and like very rarely are diagnostic procedures on exams, I feel like. And there was a question about them, and I'm pretty sure I got it right because I just like use context clues, but I remember a lot of people were not very happy about that. So I would just look over your renal diagnostic procedures. Like I said, I'm pretty sure it's an ATI. Just have like a basic understanding of it. And then the other thing really quickly with renal labs and like introduction is just like all these terms relating to urination. So micturition is the act of urination. A normal urine output is 0.5 to 1.5 milliliters per kilogram per hour. Very, very important that you remember that. Oliguria is low urine output, so like maybe between 300 to 500 mils a day, but probably around like less than 30 mils per hour. And then anuria is no or minimal urine output, so like you're barely getting 100 mils per day. Nocturia, primary urine output is at night, and then dysuria is painful urination, so like with a UTI. Okay, so so the other thing I have on here really quickly is just know like your signs of fluid overload, because kidneys, like I mentioned in the beginning, are responsible for fluid balance. So you should know like what are your signs of fluid overload. So like crackles in the lungs is the big one, edema in the legs, arms, does it pit? Anasarca is a really important term. I feel like that was on this exam as well. That's just the term for general edema. And when you do hemodialysis, you're pulling fluid off so their blood pressure can drop. But yeah. And then other things with fluid overload, so like jugular vein distension, you can have LOC changes because you have hypertension from that, and then like skin turgor, like issues and tenting and itching. Okay, that is all I have on urinary, A&P, and labs. So that's like your introduction. So now I'm going to do renal calculi. So I don't know if you guys got all the way through this, but I'm just going to go through it because it's going to be on your exam. So I'm just going to get right to it. Okay, not much, but okay, so a urinary tract obstruction can happen at any level of the urinary tract, but urinary tract calculi is like the most common form of obstruction. So that's a kidney stone essentially. And so the biggest thing with kidney stones is that there's multiple different kinds, which I had no idea until this class that like there were a bunch of different kinds of kidney stones and like they're made of different things. So that's why it's really important if you have a patient who like is concerned they have a kidney stone, like you need to find out what it's made of, because that's gonna like be really influential into like the diet teaching that goes along with it. So that is like the main thing. So sorry. That is the main thing with kidney stones is the nutrition teachings. And I know we had a question or two on it, so hear me well. So there's 5 categories of stones. So you have calcium phosphate, calcium oxalate, uric acid, cysteine, and struvite. So basically, if you have these stones, like I said, there's different foods that you want to avoid. So if you have calcium phosphate, you want to avoid animal meats, dairy, dark sodas, and broccoli, because all those things have phosphate in them. I have that bolded, and I'm pretty sure that was a question. Very, very easy question if you know, like, that's what happens. Calcium oxalate, I have all these highlighted. Calcium oxalate, you want to avoid spinach, nuts, dark rugae, asparagus, cabbage, tomatoes, chocolate. I don't know what that says. That's scribble. So that's what you want to avoid with calcium oxalate. Uric acid, if you guys just like think back to gout when you guys talked about that in patho, uric acid, you want to avoid like your red meats, your organ meats like liver, and shellfish because of the uric acid deposits that can form from that. Cysteine, you want to teach your patients to drink plenty of fluid, plenty of water, and they should limit their sodium. So like their salty foods, like fast food, that sort of thing. Struvite, you should encourage them to drink acidic juices, so like grapefruit, orange juice, because it can help dissolve. Registered Nurse RN has a very, very good page on kidney stones, and that's like how I was able to study this, because if I remember correctly, Schneider, like, he originally only gave us, I think, like 1 or 2 examples from each, but like having more examples of each food, it just like, it helped me. But like I said, I know we had at least 2 questions. I'm pretty positive about the diet stuff. So kidney stones, like I said, they're like the most common cause of obstruction within the urinary tract. There's 2 common places. So you have the UPJ, which is where the ureter crosses the iliac vessels, and then you have the UNVJ, which is the I can never say this, ureterovesical junction. You don't need to know that. So signs and symptoms, pain. That is your number 1 symptom with a kidney stone. I'm sure there's at least one of you that has had a kidney stone. I have not, but my mom did, and I just remember it was so painful for her. They also say that kidney stones like affect men for some reason a lot more than they affect women, or at least I know like men tend to be more painful and like more complaining when they have kidney stones. I think it's because it's harder to pass them just because of like the male anatomy. I don't know, I could be making that completely up, but pain is your number 1. So you're gonna have like flank pain, colicky pain, your CVA pain, which is your cerebral, oh my gosh, what does that stand for? Something vertebral angle. Why can I not remember that right now? Sorry guys, it's like late when I'm filming this. I don't know why I like put this off until now, but costovertebral angle. So it's like the bottom of your rib cage, like the 12th rib. So it's like a 90-degree angle. But yeah, just pain. Diagnostics, like I said, you want to figure out what it's made of. So you're going to look at urine. You might do a CBC to see if like there's any other lab values that are elevated. IVPs when you like insert dye and take an x-ray to see if you can see it. But the treatment is obviously you want to get out the kidney stone. So you're going to be increasing their fluids a lot. You might put them on antibiotics just to make sure they don't get an infection, because obviously if you have something obstructing your renal tract, you're probably more prone to infection. So you want to be on the lookout for that. Be on the lookout for like burning, itching, foul smelling, dysuria, things like that would indicate an infection, or like white blood cells in the urine. Lithotripsy is the procedure that we do to eliminate kidneys, and that's where we like bust a stone and then you remove it. And so one thing that I think is really important with this is this procedure is not as beneficial for like not just obese patients, but also like patients that just have like a thick body composition, so like bodybuilders, because it's totally based on like the stone size, the location, composition. So like if you're a patient that isn't like a candidate for a lithotripsy, then you might have to have like an open surgery or a stent placed. As far as nursing priorities and nursing interventions, pain and preventing obstruction recurrence through the dietary modifications that we just talked about, that is like your number one thing. These patients are going to be in a ton of pain, so you want to make sure that you're like monitoring their pain medication regimen and that you're just like staying on top of that. You want to make sure that you're pushing fluids. If they're a cardiac patient, they need to be on tele, so a monitor, because the shock waves could cause like dysrhythmias. You want to prevent dehydration, so they should drink about 12 glasses of water to make sure they have dilute urine. And then, like we talked about, you know, the dietary stuff, so like with the sodium, for if it's like a cysteine, too much animal protein can cause a lot of these, like can cause calcium phosphate, uric acid. Okay, so just those two. I have written down fewer than 6 ounces a day and 3 ounces a meal. I don't remember that like specific being on the exam, but I do remember like the dietary stuff. And then also they should be straining their urine to catch the stones so you can evaluate them further. Okay, that is all I have on renal assessment and renal labs and such. So just kind of a nice little introduction to this unit. Like I said, I'm not trying to scare you guys. You guys are totally capable, and I know that you guys will be fine. Sorry, I am just looking through really quickly and making sure that I don't miss anything. I think, oh yeah, I mentioned pain control, but these patients are going to be on opioids more than likely, and I'm pretty sure that was a question on the exam too. It was like, which of the following is the priority for your post-op lithotripsy patient? And I'm pretty sure it was pain. I vaguely remember that. You should also monitor for nausea and vomiting, paralytic ileus, because obviously if there's a blockage, that could just back everything up. Bacteria, did I even say that right? Bacteria in the urine, however you associate that. But that's like what I talked about with how if you have an obstruction, you have increased risk for infection. His slides only have like one word on all of them, so I like don't know like what to say. Oh, you guys also did UTIs with this. Okay, I guess I'll do UTI really quickly since I'm only at 34 minutes. Okay, so UTI is obviously very common. I'm sure there's people that have had UTIs as well. Do I even? Oh, yeah, I do. Okay, so UTI can be classified as an upper or lower urinary tract problem. It just depends on what it affects. Uncomplicated versus complicated. You guys need to know that. I know we had a question on that. So, uncomplicated urinary tract infection is like in a normal urinary tract. So, the example he gave us was a 22-year-old female who has a UTI but is like otherwise healthy. Whereas a complicated UTI is in somebody that has like another condition. So, like a catheter, if they have BPH, stones, cancer, tumor. And the reason that it's more complicated is because then you want to treat it aggressively because the UTI could affect those other like conditions. Your signs and symptoms are going to be kind of all over the place. So you're going to have emptying problems, which I've never had a UTI, but like if you've had one, you can probably like attest to these symptoms. I know people that have had them, and like I just remember them complaining about some of these. So the biggest one that I think I at least know of is like people with UTIs always talk about how they feel full, like they feel like they have to urinate, and they just like can't. So like urinary retention, they have hesitancy when voiding, weak urine stream, post-void dribbling, incomplete emptying, painful urination, they're going to the bathroom all the time, so like more than every 2 hours or less than every 2 hours. Nocturia, incontinence, they might have cloudy urine, burning, usually, okay, so hematuria is usually like a later sign with a UTI. I knew a girl that had like massive hematuria when she had a UTI, and she said it looked like Kool-Aid. Usually with UTIs, this is really important too, there's no systemic symptoms, so like symptoms throughout the rest of your body. The only time that that's like exempt is with older adults. They tend to get confused with UTIs. Very important. And they also tend to not show like your traditional symptoms or like show a fever. The other thing with UTIs is they smell terrible. If you've ever taken care of a UTI patient, you know what I'm talking about. It's just like metal smelling, like it's terrible. And you might see like white blood cells and nitrates in their urine, so that's why we do the urine dipstick. But your signs and symptoms are classified as like emptying problems. So like the active urination, so like that's the weak urine stream, the hesitancy, post-void dribbling, the retention, that sort of thing. Whereas the storage problems is like the incontinence and like the urgency, because you have trouble storing urine. And then urosepsis is when a UTI leads to sepsis because it like spreads. Diagnostic wise, so like I said, you're going to do a dipstick urinalysis, so a dipstick UA, look to see if they have white blood cells or nitrates, urine culture and sensitivity to see the bacteria and what it's sensitive to. You might do a CT or an ultrasound. Treatment is obviously antibiotics, but it's based off of the culture and the sensitivity. So I know we had a question on this, and he gave us a picture, and it was a lab result, and it showed a bunch of bacteria, and it either said resistant or, oh my gosh, what was susceptible? Yeah. Susceptible. I'm pretty sure that's what it was. So if it says resistant, you do not want to treat the UTI with that antibiotic because obviously that means the bacteria is going to resist and you're still going to have the infection. Whereas if it's susceptible, then that means that the bacteria like is killed by that antibiotic, if that makes sense. And he'll probably show you guys a picture or like have an activity where you have to figure out like what antibiotics you can give and what ones you can't. If you're confused by that, let me know because it's super easy points. It was a select all that apply, but like you should understand how to do it. Macrobid is usually your first choice with UTI. You're going to use Bactrim with increasing resistance. Cipro is so like your fluoroquinolines. Usually you save those for complicated UTIs. They're not like your first choice, and that's a lot because they have a black box for tendon rupture. You can also use diflucan. I'm probably saying these all wrong. Diflucan if it's a fungal infection. But usually UTIs are bacterial and they're usually caused by E. coli. You want to make sure that your patients are having good fluid intake, so at least 1,800 mils of fluid a day. You want to limit catheter use unless you have to. One thing I have, another medication that I know we had a question on, was Pyridium. So Pyridium is an over-the-counter medication that you can take for painful urination, so dysuria. It does not treat a UTI. Very important to understand. It does not treat the UTI. It just helps to soothe that painful urination, but it might turn your urine orange. So it's important to educate your patients on that like that's just kind of an expected side effect. You also want to make sure that your patients are emptying their bladder like every 3 to 4 hours and that they're practicing good hygiene. So like with women, like wiping front to back, not using like bubble baths or like scented perfumes down there, just like nice and clean. Okay, that is what I have with UTI. We go into depth with catheters, but I don't know if you guys did that. Oh yeah, you guys did. Okay. Wow. As you can tell, okay, I'm gonna do catheters and then I'm gonna call it. So catheters are a huge risk for infection, and so that's why, like, in the hospital, we don't want to use them unless we absolutely have to. So I don't even know if you guys like got this far in lecture, so if what I'm saying like is foreign, like don't worry, it's coming. Just come back and watch this after you do. So catheter obviously goes directly through renal pelvis. When we talk about catheters, we talk about the Houdini protocol. So basically, if a patient has a catheter, like from a surgery, it needs to be out by day 2, post-op day 2, unless like we use the Houdini protocol and like they meet this. So, okay, how do I want to explain this? So the Houdini protocol, it's HOUDIO and then NOI. So Houdini protocol. So H stands for hematuria, so gross hematuria. So if they have gross hematuria, you are not going to take the catheter out. You're going to leave it. If they have a urinary obstruction, like BPH, that's the O, you're going to leave it in. If they have, so the U stands for urological, gynecological, or perineal surgery. If they have any 3 of those, you're going to leave the catheter in. D stands for decubitus ulcer, so like an open sacral or like perineal wound, you're going to keep the catheter in, because if they have an open wound and they're incontinent and they get urine or feces or, okay, sorry, I don't know why I mentioned stool, because that is, sorry. So if they get urine on it, it's obviously going to be an infection. So you want to leave the catheter in. I/O in Houdini stands for, so if they have hemodynamic instability and they're on hourly management of I&Os, you keep the catheter in because they're critical care and you need to know, like, you need to know that they like what they're putting out. So that's why you're going to keep the catheter in. I'm so sorry. I'm obviously a lot more tired than I thought I was. So then NO, so no code comfort care or hospice. So if they're comfort care or hospice or no code, you're going to leave the catheter in, because obviously like we want these patients to be comfortable, so we don't want them just like sitting in urine. I stands for immobility. So if they have like an unstable fracture or like an orthopedic procedure or like have some sort of physical limitation, then they're going to have a catheter in. So that is Houdini. A lot of times with like orders and stuff, I remember him telling us this, it'll say like catheter to be removed by post-op day 2, and if not, follow Houdini protocol. So like if you get to day 2 and your patient still has a cath, you should go through this protocol, and if they don't fit any of this, then you can take it out. I hope that makes sense. After you have a patient get their catheter removed, they are going to have to be on a check void. So this is what I was talking about when I said Dr. Schneider made fun of me when I said pee. So if after 6 hours they have not voided, you need to bladder scan the patient, because your patient should void within 6 hours after getting a catheter removed. It might just take like their bladder a little bit of time to like wake up. So if you bladder scan them and it shows less than 150, you need to contact the MD, the PA, the NP, whoever's on service, and you need to provide a condition report to obtain orders, because obviously like that's not good. If the scan shows between 150 and 300, then that means the patient is like not super uncomfortable, so you're just going to reassess in 2 hours, because when you have 150, like that's not good urine, that's not good fluid intake. So like that's why you need to ask the doctor like what to do next, because it might just mean your patient wasn't taking in enough fluid. Whereas like once you start getting up into 150, 300, that's starting to be a concern, but we're still going to reassess in 2 hours. If the patient was uncomfortable though, then you would call the doctor. If you scan them though and they have more than 300, you're going to straight cath them, and then you're going to record the output and you're going to start all over, and you're going to do a check void in 6 hours. I one time had a bladder scan a patient who literally had like 900 mils. It's like, it was bad. It was really bad. So we had to straight cath him a ton. Another thing that can happen before you take a catheter out, like if a patient has a history of having trouble urinating after a catheter is pulled, is you can do a fill and void trial, which is where you fill the patient's bladder with like 400 mils and then you pull the fully, and so it'll like give them the sensation to go. But like I said, it can sometimes like take a little bit for them to go, because your bladder is just like not been working the way it usually does with the catheter in place. But it's very, very important that like everybody on that patient's team is aware that they're on a check void and that they need to void by a certain time. Usually they'll like write it on the whiteboard in the room and be like, patient needs to void by blah, blah, blah. But yeah, so that's what I have for catheters. You just need to be aware that like CAUTIs they're bad. And a lot of times hospital units will like monitor their CAUTIs, because it can tell a lot about like, are we performing catheter care? So like that should be performed every day. But if it's not, then might get a CAUTI. So that is that. I'm so sorry, guys. I'm like, it's literally only 11:30. Like, I don't know why I'm so tired. But that is all I have. So I'm going to leave it at that. But just know you shouldn't cath your patients unless you have to. So that is all I have for the beginning of renal. Sorry I started getting like super spacey. Didn't really realize how tired I was. So if you guys have any questions, comment, DM me, text me, email me, whatever. I will tell you guys next week is kind of hectic, because I have like preceptor shift 3 days next week, so might not be around as much, and I might not be able to do a weekly video, so just know that. But like I said, if you have any questions or you want to talk about anything, let me know. I hope you guys are doing well so far this term. And I hope you guys are having a good time with Professor Gerald's. If you have any questions about that, you can reach out to me too, but I can't really tell you a whole bunch because what happens in Gerald's stays in Gerald's. But anyway, hope you guys have a good rest of your week, and I will talk to you later. Bye, guys.